Hi, everybody. Welcome to Board of Health for the month of October. Just as a heads up, if you haven't had a chance to check your email, Frank is not going to be attending today because he is at the APHA, the Public Health Conference out in the West. I don't know if Brenda, you're going to step in to
Sure.
do his, okay. Or I was skipping it. I just wasn't quite sure.
I think you're going to skip it.
Okay. Okay. So we do not have anybody for privilege of the floor today either. So I'm going to go ahead and get right into the approval of the September 28th minutes. So if we can have a motion to approve as written from someone and then a second. We have a first from Melissa, a second from David. Any discussion on these edits? Okay, all in favor as written? I believe that's unanimous. Okay, so Brenda, we'll move on to you for financial summary.
The September 2021, which is month 9, was included in your packet. I was just rereading it. I don't think I have anything more to add to the report at this time. It's still spending lots of money related to COVID and trying to figure out really where we are amongst the 4 major divisions. So the ask can be put together to go to the legislature if necessary.
Okay. Any questions for Brenda? And so I think I just wanted to point out to board members that it isn't just COVID, it's the medical examiner program as well. So, and Brenda, that's not covered by COVID expenses, right? Is that a separate request to the, okay.
So I did put the finance department on notice that at the time I did it, we expected about a $40,000 overdraw in the ME program for this year. And we wanted to wait to get to further in the year. We'll attempt to transfer from one of our other mandate accounts at this point, but our case numbers are up, our autopsy numbers and our labs are all up.
Okay, great.
So we are monitoring that.
Okay, thanks. So the 40,000 is a projected overage through the end of the year. It's not, okay.
Yes.
Okay, any questions on that from board members? All right, so we are hopping over the administrative report. So we'll go right to our health promotion program.
Okay. Hi, everyone. So I wanted to mention that this week is Lead Poisoning Prevention Week. So just one of the national holidays to reduce childhood lead exposure. And here at the health department, even during COVID, we've continued environmental health and our nursing program. The joint team has continued to assess any children who have high blood lead levels. And then otherwise, I just wanted to give a shout out to my small team in health promotion who continues to jump in and out of COVID and continues to assist with all the communications, including updating the website and social media and keeping it relevant and regular. So that's continued to be something that, is a daily thing. And I also have a staff member who is very involved with being at the clinics and delivering the saliva test kits all over the county. So we're continuing to bolster that program a bit with Brenda's help too. And so we're able to provide that service in partnership with 211. So that's it. Thanks.
Great, thanks. And I don't know, Sam, if you or Claire want to talk about it, but maybe just a little bit of discussion about booster clinics that are coming up for folks that are listening and what the plan is for those, if there are any.
Yeah, so the booster shots for Moderna and J&J were also approved, and so all three available vaccines are available for this booster dose, and the eligibility and criteria is all on our website. So at this time, we're recommending that folks reach out to their primary care or contact or go to their local pharmacy. That we're in the midst of really planning for the youth clinics, the 5 to 11. There's discussion today, but that final approval looks like it'll be next week. And so we're really planning right now to start those youth clinics at the beginning of November, and put a lot of energy there. So again, at this time, we're not doing additional specific booster clinics, that people should go to pharmacies.
Okay, great.
Thanks.
And then you'll be releasing more information for the youth clinics once that's decided. Okay, great. Okay,
Yep.
Any questions for Sam? Okay, Dr. Klaypak, moving on to you. And just as a heads up for board members too, Karen sent out an additional email with the medical director's report, but I do think it actually was included in the board packet, or at least it's in the board packet that's on the web. So I just wanted to make sure that we didn't miss something, but I think it is the same information that is in the board packet on the web. But correct me if I'm wrong, Dr. Klaypak.
Yeah, thanks, Christina. Good afternoon, everybody. Yes, that is the same information. I had lost track probably of where I had sent it out. I did intend that you all should have a chance to look at it. I think the email bookends that report very well, because it lets you know we're in the process with the now constituted Cannabis Control Board. Such considerations are. And this is a very important time to weigh in on these issues as the board begins to look at what regulations and what rules will be set up that will actually govern how THC is marketed and in what forms it's allowed to be marketed, how it's advertised, et cetera. In the email, there was a email address to send comments to, and you could even just do something as simple as say, I got this document from our medical director, and I want to urge you to to go forth with the suggestions and attach the document. It's a political thing, and politics always is a contact sport, as they say, and so being in contact with the politicians is what gets sometimes movement in the right direction. I want to also point out that it isn't actually included in that report, but substances that tend to cause dependency, substances that tend to cause addiction, tend to be ones that achieve a very rapid rise in blood level of the substance being used. That's very important because the dynamics of the substance are often dependent, of course, on the dosage of it, but also on the route of delivery. So substances that are inhaled or smoked are more likely to be causing dependency or addiction than substances that are ingested. And unfortunately, we do allow inhalation of some things like CBD, and possibly they'll allow it for THC. It may be a marketing decision. I mean, how can we compete with the black market if we don't allow inhalation? But it's not a medically defensible position to take. And as public health people, we should not, I believe, be supporting that. I think the message should be to the public, there's danger in inhalation, and from the point of view of dependency, et cetera, but also from the point of view of chronic bronchitis, chronic obstructive lung disease, cancers, not only of the pulmonary system, but as with tobacco, we know that it causes cancers of the GI tract and other locations. So please do take a look at it, see if you can support it, and contacting folks is a good idea. On the subject of our booster clinics and so on, as you have heard Sam say, we are focusing on the 5 to 11, presuming that that's going to get approved. I'm having a thought that this Friday, we're doing a Friday morning conference for the local medical community. Friday morning conference series is held at CMC. This week's is on COVID-19, an update, and Jeff Schnedeker and I are doing the update. Jeff will focus on 5 to 11, I'm sure, and other aspects of the pediatric age group. I'll be depicting the public health view of COVID at this point. And I think what might be most interesting to our practitioner community is information they can't get anywhere else. What is the public health situation with regard to pandemics and COVID? Where do we sit? How do we view the pandemic? And unfortunately, public health departments, county health departments across the country aren't doing so well. And the New York Times did a survey of all county health departments just recently, reported it in the New York Times. And of the counties they surveyed, 400 responded. Those counties, a sizable number of them, were less well prepared to deal with the pandemic now than they were at the beginning of the pandemic. That is an incredible statement. And it has a lot to do with how we as a country view public health and how we fund it and what our reserves are. So we can't mount a response to do booster vaccinations for the people in line for boosters, and also launch a credible 5 to 11 vaccine campaign. So we are relying on pharmacies and private practitioners to carry the water. My wife just today checked with a couple of pharmacies about a booster for her elderly mother, and they're booking out into December. Some practitioners are stepping up to the plate with COVID vaccine boosters, and others are not. This is a time when we need the private sector to take action. We have to plead a bit. So on Friday, I will be pleading, and I'm going to be pleading not only for primary care to step up to that plate, but I think if you're an oncologist, if you're a gastroenterologist, if you're a neurologist, and you are the principal caretaker of a person, it's not so much to ask to get involved and vaccinate them at the point of care when they need it. So we'll see how far that goes. I hope it goes some distance, but that's the story. On our local front, since I issued my report, Dr. DeLima supplied some information for me about hospital situation with regard to admissions and the census in the hospital. And I want to front this data with some CDC data that's just recent. So across the nation, in late August, of 10,000 unvaccinated Americans, 65 and above, 24 of them were hospitalized with COVID symptoms, 24 out of 10,000 of the 65 and above. For fully vaccinated Americans, 65 and above, that same that same category, the number was 1.5 per 10,000. So 24 per 10,000 versus 1.5 per 10,000. Unfortunately, too many Americans are saying no to being vaccinated and choose to take their chances with a potentially fatal disease. When we have a proven medication, a vaccine that can prevent hospitalization and prevent death. Within the hospital, people admitted to the hospital and admitted to the ICU, it was 3-1 in favor of the vaccinated. So 77% of the ICU admissions were unvaccinated people, 23% were vaccinated people. And those vaccinated people largely are people that are extremely elderly or have other, and perhaps that plus other significant high-risk conditions. Of admissions to the regular floor, non-ICU admissions, 69% were unvaccinated, 31% were vaccinated, a 2-to-1 spread. For genders, it didn't much matter whether you're a male or female. For ages, as you got older with more comorbidities, you did see more of the vaccinated people tending to get admitted, but particularly for the people below the age of 70-ish, it's predominantly the unvaccinated, even extending down into the very young. And for fatalities, there were 11 fatalities out of the 126 admissions counted. 4 of those fatalities were amongst the vaccinated, 7 of them were amongst the unvaccinated. Again, the vaccinated people were largely people at high risk for other reasons. So the message is, I think, simple. Vaccine prevents severity. Vaccine prevents serious illness. And playing Russian roulette with COVID is not a very good idea. We have our fingers crossed that we might see this downturn in Delta continue on. However, as you know, past performance, as they say in finances, is no guarantee of the future. However, past performance on a communicable disease sometimes should give you great pause. And we've seen the rise of mutations, take over, et cetera, especially when the ancillary measures of masking and distancing start to go away. And I would just urge again, everyone to use common sense. And even if you're vaccinated, it's not worth it to take the risk. And prevention measures work. That's a relatively long addition to my report. Sorry, Christina, but if there are any questions, I'll be glad to take them. Thank you.
Yes, no, I think people listening are interested in it, so appreciate that you went into that level of detail. Melissa.
Hi. What are you recommending for boosters for people? Are you recommending that they stay with the vaccine that they originally got? Or mix and match is okay? Because I did call around yesterday also to see who had Moderna vaccines, and they're booking out till December. I even tried getting an appointment in New York City, and it seems like Moderna is harder to find than Pfizer.
So of course, you know, the formal recommendation from the CDC is to stick with your the vaccine you got originally. But on the practical level, sometimes they're not available, right? So mixing and using a different mRNA vaccine, or departing from Johnson & Johnson and going to an mRNA vaccine, yes, that can be done. For certain categories of people, they may wish to not use the vaccine they got originally. For example, if you're a young female young being below the age of what, in the 40s. The risk of the clotting disorder, which is a very severe risk in terms of its outcomes, although very rare as a complication, very rare. But you might say as a female under the age of somewhere in the 40s, I don't think I want to do another Johnson & Johnson. Let me do an mRNA. And that's perfectly allowable. One can do that. There are various considerations that come up for people, which might argue for them to switch. But the data out there about the booster antibody level that you get with one booster compared to another, with Johnson & Johnson, a lower level of antibody boost compared to Pfizer, and then Moderna having the greatest antibody boost, can make people think, oh, maybe I should do a Pfizer or Moderna if I got a Johnson & Johnson before. Antibodies are not the same as absolute protection. And at this stage of our knowledge, we don't have that clinical information which would say that there would be a tremendous difference between one booster or another. Antibody levels are being used as a surrogate, as a substitute for knowing what clinical disease would be avoided. And we don't really know what antibody level is minimally needed for protection. So that's where the antibody levels don't give us all the information we want. But we do know that the booster with Moderna gives the highest after the primary of Johnson & Johnson, followed by Pfizer, followed by Johnson & Johnson. That leads one to have to say something about information and the criticism that we hear from the public oftentimes. Oh, well, you really don't have all the answers, so how can I believe anything that you're telling me? And what really is happening is that we do have a lot of answers, and that we are changing our recommendations as we go forward because we are paying attention to the data, because we are looking at what good studies are telling us, reliable studies that are done in the proper manner. Not like a lot of these studies out on the web, which are shoddy, give poor information about the pandemic and about some of these alternative therapies. They're called unproven uses of medications that have really no basis in science. The fact is that we are following the science. When our recommendations change, they're based on the best information available, not by some sort of fly-by-night posting on a web or something. So that's a long answer to your question, Melissa.
Thank you. Any other questions for Dr. Claypack? Okay, Claire, do you have any additional items to follow up on from your division's perspective?
Good morning. I don't have much to add to the report. I would just maybe kind of highlight that and echo some of what Dr. Kay mentioned as well. First off, thank you to the Health Promotion Division team, because the internet accessibility and the website table, it's so important to people, and they tell us when they call how valuable that is. And I really appreciate that that's a constant source of reassurance for them and a way for them to monitor and feel empowered. So thank you. We continued over September to see record cases, and the division was really busy with clinics and surveillance work and responding to the public inquiries. The team was expanded a significant amount. We're really lucky and appreciative of all the resources that we were able to throw at this Delta variant and the wave that we were experiencing. We navigated the back to school transition in September and have been able to stay up with cases and prioritizing efforts on the busiest days to ensure that the K through 12 cases were addressed first and foremost. And just wanted to reassure that all cases are investigated or attempted within 24 hours of receiving the lab results. And as work flow at the state level has diminished with catching up, they are now assuring us all contacts that we are sending to them are being contacted the same day. So that's good news. And just wanted to mention again how important it is for us. We continue to count on the community members to support our efforts and engage with us to stop the spread of COVID and to protect the most vulnerable in society. And I think, we saw this in the spring. There's a certain level of fatigue and frustration that we've noticed, and that's certainly understandable. So I think continuing to engage in dialogue and being open and honest with what we know and don't know, and I think is really continually important for us. And I just wanted to mention kind of generally, there's so much change and uncertainty. We're trying to build momentum to kind of guide our vision for moving forward with our team, Community Health Division, how to transition when we have that possibility to our other important work that's been put on hold. It's not for this month of September covered in this last Board of Health report, but in October, the team did an incredible job addressing flu clinics and getting back into the rhythm on top of all of the COVID clinics that they were supporting and preparing, as Sam said, for the booster and the child's vaccines as well. We're excited to link with the APHA themes that are coming out at the conference. Sam has worked to sort of live stream some of these and allow everyone to participate in the ones that they're interested in. It's important to reflect on our purpose and our role at a broader level as a health department, and remembering that we're not alone in our challenges. And also just a chance again to call back on what we've learned, what we've experienced, particularly with this last wave. The last 3 months have been incredibly eye-opening and I think added to what we already learned and took away from the first several waves and experience with the pandemic. So what we're really aiming for is a flexible, efficient, high-quality response mechanism and a way to avoid burnout and ensure that data is collected and used to inform our decisions so we can build trust around the science and the policies that we're developing. So I just wanted to mention that, that's kind of where we're at, and look forward to when Frank comes back discussing with him what he's learned from his colleagues. And it is really, we're feeling a bit of space and room compared to the last 3 months with cases coming down. And I just, I think this is the time to connect to those larger themes and learnings. And just a last kind of update that wasn't in the proposal. It was a joint effort with health promotion team that Sam led. We applied for a grant opportunity that we just couldn't turn down despite not having the time or resources to fully commit to it. We actually pulled in community partners and did a joint submission with them. And Sam led that initiative to collaborate with CMC, CCE, Health and Human Services Coalition, and other partners for a program that focuses on maternal health disparities and a community health worker approach. So it's just a reminder that these are important issues that need our attention, and just really look forward to being able to devote resources to that again when we can. So thanks.
Thanks, Claire. I'm glad to hear that your team is getting a little bit more breathing room to start to look at some other important public health stuff. Okay, any questions or comments for Claire? Okay, Deb, I think you're up next.
Hi, everyone. I don't have anything additional to add to my report today.
Any questions or comments for Deb? Okay, and Jonathan?
Yeah, as I was sitting here, it just occurs to me that the next meeting of the Board of Health will be my last. For those of you who don't know, I'm retiring in December.
I didn't know that. Congratulations.
Oh, thanks. Bill Troy will be the next county attorney. He was appointed at the last legislature meeting. I don't know whether he will do the health department work or whether he'll have somebody else do it. I don't know that he's made that decision yet. I was thinking about, I've been here 29 years, and I was just thinking about my first Board of Health meeting and who was on it, and Francis Racker was on it, and Jim Rice was on it, and F.H. Fox. And I was thinking Frank Proto is probably the only one I know is still alive. So makes me feel old. But next one will be my last meeting, and Bill Troy will take over, and you'll help. I mean, it's obviously not just Board of Health, it's the health department as well.
Great. Well, thank you so much for everything you've done to support us. Do you know, will we be back in person by December, or will we still be on Zoom in December?
So the law
Uh-huh.
passed by the state goes to, I forget the date, it's January or February.
Okay.
But whether we do that or not is optional with us. So the county legislature has adopted a policy that it is optional to do, including to the county legislature itself. So it's optional. But if the Board of Health wants to meet in person, it can.
Okay.
The issue is really under the Freedom of Information law, are you allowed to or not? So yes, through December, and I forget the exact date that the law ends, but my guess is it may be extended to, I forget whether it's January something or February something. And then I'm sure once that, if that ends, you know, because it may be extended, that the legislature will have a new policy at that point. But I think honestly, many of them enjoy, you know, appearing by Zoom. However, you know, we're going to have at least 5 new legislators starting in January. So we'll also have a different legislature, and they may feel differently about it as well.
Okay. Okay. All right. Thank you.
Sure.
Any questions for Jonathan? Comments? Okay. Liz.
I don't have anything to add to my report.
Okay. And then Harmony.
At the last Community Services Board meeting, we had a guest speaker, Jed Wolkenbright. He's the counsel for the New York State Conference of Local Mental Hygiene Directors, and he did a wonderful presentation for everyone that lasted our entire time. And Christina, I believe you were there.
I was, yeah.
And he did a nice job on giving us the history and the role that the board plays. So that was what we did at our last meeting.
Yeah, and I couldn't remember, Harmony or Karen, if that PowerPoint went out to the full Board of Health that he did. Okay, so I'll make sure to send that around to everybody, because it was really a good presentation of history as well as sort of where we are today. And I think that it would probably be good to just familiarize yourself with that, particularly as we hopefully at some point here transition out of COVID and also start spending more time on the integration process. I think it's good background. So, okay. All right, so with that, we'll move to our environmental health actions. And so our first resolution is related to on the street throughout Tompkins. Enforcement action number 1. Yes, Sam, I will. I saw you. I'll send that around. So if we could have a motion to approve as written. From Melissa, I need a second. From Ravinder, okay, Liz, any discussion or any additional information aside from what's already in the packet?
No, there's nothing additional that's not in the packet.
Okay, any questions from board members on this for Liz? Okay, all right, so let's go ahead and call vote on this. All in favor as written? I think that is unanimous. So no opposition or no abstentions. Didn't miss anybody, right? Okay. Our last two are administrative actions. So these, I believe, Liz, you just discussed, and then we vote up or down on. So can you start with the brewer request?
Yes, this was an interesting situation. It was an illegal, I guess it still is an illegal subdivision that was developed on Shelter Valley Road with very small lots. And they now have public water, which helps. But these are very small lots. I think the lot that this person bought had been abandoned. It had been abandoned for more than 5 years. And then under our sanitary code, you then have to put in a sewage system that is in full compliance with all of the sanitary code requirements. And that is impossible on this lot. We are proposing that we treat this as a replacement sewage system because we can put in enhanced treatment units when it's a replacement system, which provides, that's what we do on the small lots down by the lake and stuff to get better treatment, since a lot of those are also tiny and very, very old parcels. So we're proposing to approve this waiver request that this system can be treated as a replacement on the condition that they put in an enhanced treatment unit or ETU with their sewage system.
Okay. So any questions for Liz about this waiver request, which the staff is recommending that we approve? Okay, all in favor of the waiver? I believe that's unanimous. Okay, and then we have a second waiver request.
Yes,
Yeah.
yes, this one, he owns a mobile home park, and he has put in, which is a public water system, and he's put in a request to waive the water system fee. We have an operating fee to cover our oversight. So he's turned in a request to waive that fee, and we've submitted this letter. It's kind of a, it's not a straightforward situation for us, so we did not put in a recommendation, and we'll leave it up to the Board of Health. He's a mobile home park owner. His mobile home park permit is also expiring very soon, and he hasn't put in a request to waive that fee. His water system, he has not necessarily submitted all of the information that he needs to, monthly operating reports. He's missed some sampling. He had some results that were unsatisfactory. He did resample, but this situation has created, we're expecting it to be a situation that requires more oversight by us than, just the typical mobile home park that's also a public water supply. But then, there's also concerns about if we don't grant the waiver, if you guys don't grant the waiver request, right, then we'll probably end up, he'll be operating without a permit. We'll probably take enforcement, and that adds more fines. So it's it's not a straightforward situation. That's my best summary, I think, of it.
Okay, questions from the board for Liz or discussion on this? Melissa?
Would we be able to, instead of waive it, extend the deadline for him paying it?
We can do a setup, we can waive, like there's late fees. We could waive the late fees. That is not necessarily uncommon in difficult situations. So we could waive the late fees and we can set up a payment plan for him. So that's what we would do. Like the payment plan essentially extends the option. Another thing I meant to mention was that, the mobile home parks are, technically for-profit operations, and we have not typically waived fees, except during COVID, for for-profit operations. Mobile home parks are, again, a funny category because of the population that they typically serve, and then expenses are passed on to the residents often.
Sue, and then David.
So Liz, you said you don't typically waive these except during COVID. So has there been other examples where the fees have been waived because of extenuating circumstances in the pandemic?
We did waive some fees for restaurants, because like some of them had to shut down right away. So I think we did waive some of those fees, is my record. That would have been brought before the board if we're going to waive something like that. And I think we are waiving the late fees and stuff during COVID.
Okay, David.
So it was typically the people that were unable to operate, right, that really had their operations restricted.
You mentioned that I understand how his income is drastically reduced because people weren't paying the rent and there may not be any relief for that. But you also mentioned that maybe he was a little bit behind on, is it just the paperwork? Does he have a good history of running a good water system, or is this a guy who's always given us problems?
So no, one of his most recent water samples was positive for coliform. He did take the necessary additional samples after that were satisfactory. But so it's a unknown situation. And it is not, we do not know that his lack of rental income is from the mobile home park. He has other properties, is our understanding.
Okay, any other questions? Okay, so since I think I heard two suggestions here, and Jonathan, just correct me if I'm not doing this correctly. So why don't we, can we vote first on whether to approve the waiver request as written? And then depending on the outcome of that, since it seems like Melissa also raised the question of, would it be possible to approve a payment plan? Do that as sort of a second question, or should I, what do you recommend?
The way it's typically done is someone would recommend an amendment, and then they vote on whether to amend the main motion to be that. So kind of the reverse order, and then vote, if that passes, then that would become the amended resolution. If it doesn't, then you vote on that.
Okay, and I didn't put this under the same motion when we started. Okay, so let me ask the board, does somebody want to put a recommended motion on the table right now? Melissa.
Okay, could we recommend that we delay his payments, waive his late fees, and put him on a payment plan when he is able to pay? This way we get reimbursed for all the work that we'll be doing, but it really has been a hard, I don't know how many months, but a lot of months.
Okay, so sorry.
The only comment I have on that is it's the last clause about when he is able to pay, because that's subjective, I think, and difficult to determine from our perspective.
Could
So
we,
to me, it
could
would
we
need
bring
to
it up?
be-
Sorry.
Go ahead.
Could we defer it until some other meeting and then see if we have more information?
Liz, what's your typical payment plan structure?
It varies with the individual. We do try to negotiate with it with the parties.
Okay,
I mean, Norm, that's not brought to Board of Health typically,
Right.
right? We just do
right.
that.
So if Melissa, would you be comfortable with amending your motion to indicate that to ask for a payment plan and waiver of late fees? Is that sufficient for you? Okay. Can somebody second that? Or does somebody want to second that? Okay, lots of people seconding that. I'll take Sue for this one. Okay, any additional discussion needed on that motion? All right, all in favor? I think that's unanimous. Yes. Didn't miss anybody. Nobody opposed or abstaining? Okay. Okay, Liz. All right, any other agenda items that we didn't cover that need to be discussed? Okay, folks.
So now you have to vote on it as amended.
Oh,
So you voted to
Okay.
amend it. Now you
sorry. Thank you. Okay, so now. Okay, so
What
I
are we
can just.
gonna do when you leave, Jonathan?
I don't know, like it's too hard. It's too hard to remember all these steps. Okay, so now we're voting on, Jonathan, what do you want me to vote on? We're voting on the amended plan, basically, right?
Right, you're voting
Okay.
on amended motion.
Right. Okay, so we can just go straight to voting, right? So all in favor? Anyone opposed? Abstentions? I think that was unanimous.
So could I add
Do I have
something
to open
else?
up for discussion?
Could I add something else out of order?
Yes.
So I looked up the date of, I mentioned that the state law ends in January or February, ends January 15th. I don't know if you set the dates for your meetings next year yet, but you may want to think about that in setting the January meeting. And I don't know which way, whether, if you set it before the 15th, then clearly you can do it by Zoom. After the 15th, it's unclear.
Yeah, I guess we haven't set meetings for that next year yet, have we? I don't see it on my calendar, so I'm just looking. Okay.
Right, so you'd probably do that on a resolution at the December meeting. But I'm just saying you may want to think about that just for the January meeting, whether
Yeah.
you.
Yeah, and we would be meeting after the 15th of January for sure, assuming we follow our normal
Yeah,
schedule.
assuming you follow the current
Yeah.
schedule. If you want to be sure that you would be able to meet by Zoom, and you may want to set the January meeting for before the 15th, but that's obviously, up
Okay.
to you.
Okay, I'll talk to Frank when he gets back and see what his thoughts are too. Alrighty. Anything else? I think we've satisfied all agenda items. Okay, so we'll go ahead and adjourn and then see everybody in is it late November or early December, I think. Yes, Ed.
Early December.
Quick question, did we ever have Liz give her information about the past?
About what?
I don't think Liz, did you talk about, I guess, the department? I think we skipped you in the, no, we didn't?
No, she declined to
Oh,
provide.
you declined, okay. I must have
Yeah.
missed it. Okay, sorry about that.
Yeah, she said that
Okay.
her report was complete.
I didn't want you to, we didn't want to miss out on you, that's all.
No, but thank you for
Something
asking.
lengthy or something like that. I'm surprised. Okay, thanks.
Okay. All right, everybody. Have a good month. We'll see you next month. Bye.
Bye.